Good day. We're going to talk about drugs for GI disorders. So primarily we're talking about um, PUD, peptic ulcer disease, GERD, gastroesophageal reflux disorder, um, diarrhea, constipation. Um, some of your chapters are over nutrition. If you haven't read those yet, I didn't spend a lot of time on it because I'm really not going to cover that much for this unit. Some of the things you want to review to prepare for this unit is, what's involved in digestion, the acids of the stomach, how those turn on the stomach to cause the diseases of PUD, what's involved in elimination, so that you can understand diarrhea and constipation. Refresh your memory on PUD and GERD. We're not going to ask questions on the test related to disease processes. We're focused primarily on the drugs that treat those diseases. But again, you sometimes have to understand the disease process to understand the purpose of the drug. So antacids are usually the first line of defense that people use when they have heartburn. Heartburn may be a symptom of a bigger underlying disease, such as PUD or GERD. So antacids are easily available over the counter, but we need to educate people that, if those things aren't effective in a short period of time, then we probably need to seek further help with that. So antacids are alkaline compounds, typically made of aluminum, magnesium, or calcium. Aluminum hydroxide and magnesium hydroxide are pretty common. We also see a lot of calcium-based antacids over the counter. The action of antacids is to decrease the acidity of gastric secretions by buffering the hydrochloric acid that's produced by the parietal cells. It doesn't block the production, doesn't change the production in any way. It simply makes it more neutral because they are alkaline products. It's going to bring it closer to a neutral, and the gastric acid or gastric juices then lose their corrosive effect. So they're not going to destroy the mucosal lining of the stomach because of the lack of corrosiveness. Antacids were probably the first line of defense, or maybe even the only line of defense, prior to the development of H2 receptor antagonists and proton pump inhibitors, which we're going to talk about. They're inexpensive, so people could pick up a bottle for $1, and typically they're going to do that first. Simethicone is added to a lot of antacid preparations because it reduces gas buildup. Simethicone is frequently used in anti-flatulent compounds or medications. What it does is breaks down larger gas bubbles into smaller ones so that it's easier to pass. That's just kind of a side note. Aluminum compounds have to be observed for the complication of constipation, especially when taken in large doses. And magnesium compounds, on the other hand, can cause diarrhea. So side effects we want patients to be aware of. Otherwise, it's fairly difficult to take too much antacids. The other complication would possibly be change in acid-base balance if the antacid use was truly excessive. The other thing about antacids is that people with renal failure should avoid the magnesium and aluminum-based antacids. They can't excrete that ion, and therefore aluminum is a heavy metal. Magnesium can build up and cause toxicity as well. So we need to be cautious of that as well. Frequently, antacids are high in sodium, so patients with on a sodium-restricted diet or who have hypertension or heart failure need to know that as well. We also want to make sure that they understand when not to use an antacid. If they have coffee ground emesis, bloody stools, abdominal pain, they need to seek medical attention rather than just treat themselves. People with PUD frequently benefit from a liquid form. It's kind of coating, and tablet forms, usually if we have the patient chew that tablet first, they will get a better faster onset of action is what I'm trying to say. No, I hope this is still recording. I'm having some issues. It appears it didn't want to go, and then it went, and then it went anyway. So we'll see if I'm going to redo this or not. H2 receptor blockers, ranitidine or Zantac. Of course, you can get this over the counter now. Typically used for PUD more than GERD, but it is used for PUD, peptic ulcer disease. So, ranitidine is the drug of choice for H2 receptor blockers. Its action is just what it says. It blocks H2 receptors. Now, H2 receptors are found in the GI tract, and they stimulate the production of gastric acids. So we want to, if we block the receptor, then we suppress the volume and the acidity of stomach acid. We want to make sure that prior to use of an H2 receptor blocker that baseline central nervous system and liver function assessments are done. Because side effects can include changes in level of consciousness, hepatotoxicity, obviously. CNS changes can include dizziness, headache, somnolence. It can cause diarrhea or constipation, depends on the patient. We might see confusion, disorientation, hallucinations, gynecomastia, and of course hepatotoxicity. Most of our adverse effects are dose-related, so the lower the dose, the better. Cimetidine, which is an H2 receptor blocker that's been around for quite a while, is worse about the adverse effects than the newer ones. Make sure that patients know it can be taken with or without food. If used with antacids, we should give the tidine 1 hour before or 2 hours after the antacid. Patients need to know that it might take several days to see relief once they start using the H2 receptor blocker, the tidines, and it can take 4 to 8 weeks for an ulcer to heal. GI prostaglandins, such as misoprostol or Cytotec, is a prostaglandin-like substance, and the prostaglandins, along with the stimulation of the H2 receptors, helps to stimulate production of gastric acid. So misoprostol inhibits gastric secretion and stimulates production of the mucus. Well, what does stimulating production of the mucus do? It's going to help to coat the mucosal lining and protect it from the acids of the stomach. Misoprostol is primarily used in the prevention. It might be given along with patients that have to take high doses of NSAIDs. For instance, someone with arthritis. Because we know NSAIDs irritate the GI, then we could give the misoprostol in order to not only reduce the gastric acid, but also offer more protection. Glucocorticoids would be another drug that can irritate the GI, and so misoprostol would be something that would be useful for them. Some of the things we need to assess prior to use: are they pregnant? Because misoprostol is since the prostaglandin-like substance can induce labor. And we want to check their bowel pattern because it can cause diarrhea and abdominal cramping. We want to know what was occurring before to know, is this a problem with the medication? So adverse effects are diarrhea and primarily dose-related, and usually don't start right away, but after prolonged use of the misoprostol. We can encourage patients to take in more roughage or fiber. That if they take it with meals, it may help reduce some of the problems, and that they should avoid magnesium antacids when they're taking misoprostol. Proton-pump inhibitors, we know that they end in prazole. I almost said Prilosec. The prazoles, there's numerous of them: omeprazole, pantoprazole, lansoprazole. They inhibit this enzyme, the HK-ATPase enzyme, which is responsible for secreting hydrochloric acid in the stomach. And so if we inhibit that enzyme, then acid secretion is reduced, which is a good thing. And the proton pump inhibitors, as a general rule, work better than the H2 receptor agonists for reducing acid secretion. Use of proton pump inhibitors typically should be short-term. Again, we want to assess the bowel pattern prior to use because it can cause diarrhea. Patients need to, again, be aware that it can take time to see improvement A little faster with the H2, it takes, a few days, but with proton pump inhibitors, it may take up to 2 weeks to see improvement. Now, coating agents, many of you are probably familiar with sucralfate or carafate. Sucralfate is a compound of sucrose and aluminum hydroxide. When it could be a liquid or a tablet, but when swallowed, it produces a thick gel-like substance that coats the ulcer. So it doesn't affect the secretion of gastric acids or alter the pH of the gastric acid. It simply protects the ulcer from the acid that is present. This promotes healing and can alleviate discomfort as well. It should be given before food, usually an hour before meals and at bedtime. So that can be one of the downfalls, is that it does have to be taken 4 times a day. So compliance could be an issue, especially if they don't have regular meal times. But side effects, there are very few side effects because it isn't systemically absorbed. Mostly we get GI effects, which can include constipation, occasionally dry mouth, both of which typically resolve with continued treatment. So they build kind of a tolerance to that. Prokinetic agents like metoclopramide are less about PUD and GERD, though they can be useful for PUD and GERD, because if we empty the stomach faster, then we get rid of the gastric acid buildup. But prokinetic agents, you can kind of tell from the name, pro for kinetic, which is movement. So basically they're gastric stimulants. They increase gastric emptying time, or they increase gastric emptying by decreasing gastric emptying time. So, usually the stomach only empties every 20 to 30 minutes or whatever it does. But we can speed that up so that it stays empty longer. It also increases peristalsis of the intestines. And all of these things can be good things. So why would we want to increase gastric stimulation? We can use it for esophagitis that occurs because of gastric reflux. If we empty the stomach faster, there's less acid buildup to wash into the esophagus. It can be used post-operatively to prevent nausea and vomiting, or for a patient with an NG tube, again, to prevent nausea and vomiting. It helps to return peristalsis to the intestines after surgery, abdominal surgery, or an anesthesia, so less risk of an ileus. It can also be used to prevent nausea related to chemotherapy. So it has lots of uses, and you may have seen it given in clinical. Some of the things we want to assess for prior to using a metoclopramide is, does the patient have a history of epilepsy? Do they have diabetes, because it can cause hypoglycemia? Do they have symptoms of GI perforation, obstruction, or hemorrhage? Obviously, these would be times when we would not want to increase peristalsis or contraction of the stomach muscle. Implementation, if it's PO, give it before meals. If it's IV, it can be given anytime without regard to meals. Common side effects include drowsiness, fatigue, lethargy, dizziness. Serious side effects are the extrapyramidal symptoms, similar to what we get from treatment of Parkinson's disease. So if they're on anti-Parkinson's meds, we would want to question the use of metoclopramide as well. Antispasmodics, they usually are anticholinergics. I don't know why I don't have any med names, and I can't think of any off the top of my head, but nevertheless, they are anticholinergics, so they decrease saliva, they decrease pepsin and hydrochloric acid in the stomach. They, however, as you know, anticholinergics have a tendency not to do. They don't just affect the GI. They're going to affect, cause tachycardia, changes in pupillary response, but we might use them to decrease peristalsis, which might be useful for diarrhea. So common side effects are going to be blurred vision, constipation, urinary retention, dry mouth. We know all of those. Serious side effects: confusion, depression, nightmare, hallucinations, palpitations, and dysrhythmias. So we know all about that stuff for anticholinergics because we've heard it every week for 3 weeks now, have we not? I was going to see if I could find out really fast exactly what meds would be used in this capacity, but I'll have to get back to you on that. Now, I'm not sure if this is in your book or not, but Helicobacter pylori is a bacteria that is has a high association with as the cause of ulcers. So a lot of times, simply eradicating this bacteria will cure the ulcer or allow it to heal, along with other treatment for the active ulcer itself. So they can do a simple blood test to check for the H. pylori and then prescribe antibiotics for that. Okay, so that's it for GERD and PUD medications.